Hi, my name is Sadaf Sajjad. I am at ACC, work as an adjunct associate professor in psychology department. And today I'm here to talk about global mental health. So let's just start this topic, global mental health. What is global mental health? What actually is mental health, first of all? Today what we are going to do is, I'll be talking about these things, and we will be defining global mental health. We will have some debate or question of defining abnormality globally. So what is normal, what is abnormal, how can we define it globally, and then as an example on the basis of diagnosis, treatment, and how do we treat psychotherapy, that is, we will be doing some case studies from other side of globe with emphasis on cultural variations, diagnosis, and treatment plan variations. So 3-4 case studies will be discussed in it, in which we will show how they are differently dealt in different areas. Then global mental health statistics, what is going on nowadays, and then we will be talking about some current issues in global health and current work or steps taken to improve those issues. And then some suggestions and some solutions related to global health. Let's define global health, global mental health. Basically, it's a worldwide viewpoint on different aspects of mental health, such as when we study different disorders, different kinds of abnormalities, what are the reasons for those abnormalities, or what is normal and what is abnormal. We differentiate between them, we study, then we do research. Which kind of disorders occurs, because of what reasons, or at which parts of different places, what are the impact of culture on that kind of abnormality, what are the different aspects we have to study related to any behavior. So we do research in that area. We study, we research, and then we improve mental health by our study and our research. So improving mental health and achieving equity and impartiality in mental health for all people worldwide. That means providing treatment and prevention globally for any abnormal behavior or abnormality. That is all about global mental health. And now comes the question of defining abnormality. So when we are studying, we are researching, we are planning treatments and preventions all around the globe, then comes the question of how will we define abnormality. So basically, in order to define what is abnormal behavior or abnormality, first we need to define mental health. What is mental health? Basically, it's a unified, uniform definition for everyone. Emotional well-being of any individual, psychological well-being, and social well-being. That is all related to your well-being, and that is all part of your mental health. And what is emotional well-being? Thinking, believing positively, and then you have a sense of overall well-being psychologically about yourself. And then you are related to a society. You work in a society effectively. How you deal with different kinds of problems, and you give up solutions, and you work efficiently within a society, which we all are part of some society. And all this is related to psychological or mental health. There is a universal fact. No matter at which part we all belong, no matter you belong to West, I belong to maybe East, and every individual living all over the globe, they think, they feel, and they behave. They don't have any difference in that. So this is what we are globally uniform at. But there might be a difference how I handle my stress, how you handle your stress. So that could be a difference between two human beings, or more than two, maybe, depending. Then how we relate to others. Maybe I am different in that, maybe you are different in that. How I make my choices and how you make your choices, that could be a different thing. So mental health is important at every stage because we all think, feel, and behave, and we all are related to all these things, but that could be different, how we handle that other things. And it is important at every stage of life of every person, from childhood to adolescence, in adulthood, in older age as well. So it is important. And then comes the question of what is mentally healthy and what is unhealthy. So once it is established that we all think, we all behave, we all act in certain manner, but our differences may come how we behave, how we think, how we are. Am I a positive person? Am I taking things positively? Am I taking everything negatively? Or how I'm just relating to my stress? So how I'm taking the problems, like why I am saying that this is healthy, this is not unhealthy, this is unhealthy. So the problem of normal and abnormal is defined on the basis of two popular views. One is abnormal as a deviation from social norms. So depending on your norms, you define things. What is your norm? Your social norm could be defined by the society. You are raised up in those social norms, and that's why on that basis you might define something normal and something abnormal. Then there's a second category, that is abnormal as maladaptive. That means that you have been clinically, let's say, diagnosed by some disorder, and that is universally accepted as per the rules of some diagnostic and statistical manual. So I can explain it with some examples. So number one is the abnormal as deviation from social norms. If you look at these figures, you can just look at the figure. These are two figures of females from two different cultures. And you can see that one of the figure is someone is wearing a whole, complete, covering the whole body, and that this kind of dress is known as burqa. In this dress is in some parts of the world where there are patriarchal societies exist. This dress, this kind of clothing is considered as something attached to sense of honor, something attached to, they feel very good in that. They wear it and then they feel very good in that. Similarly, there's another dress, and that is a kimono from Japan that has some sense of, which represents their history, and at their good, like their big occasions, they used to wear this dress. A person who is not culturally literate won't recognize them that this is something very normal in few societies. And if these people go to that society, maybe, they will be recognized as they were something wearing abnormal. So based on their own knowledge, based on their own setup of their society, they are defining few people on the basis of those clothes which they are not familiar with, and they might define it that this is something abnormal. And I have asked my students in my class showing these pictures a long time ago. My students, when I showed this picture, most of my students said that they looked like a terrorist. So see how much difference of defining something, but they look like very normal in few societies. People know them, that this is kind of a dress. Okay. So this is how sometimes we are just defining things because of our ignorance of other people's culture. And this becomes the basis of something. We are distorting the global aspect of the mental health. Then there is a second aspect, that is abnormality as maladaptive. So as you can see in the figure, this is the DSM-5. DSM-5 is Diagnostic and Statistical Manual of all psychiatric disorders, which this mental disorders are the symptoms, their duration, and their background is written in this manual, and this is a standard for universally everywhere in the world to follow this book, and that has been like given by American Psychiatric Association. This book is written here. Although very carefully this book is written, cultural aspect has been seen and put in this book, but there are so many things which are still missing. So we will discuss that as well. So abnormality as maladaptive means, an example I can give you, that if somebody is diagnosed having a, let's say, bipolar depression, that bipolar depression is diagnosed on the basis of symptoms, the duration, it was there, and that's how, like, then a person is clinically diagnosed on that bipolar disorder according to this DSM-5 in every part of the world. So nothing to do with the norms. So any part of the world, if someone comes with the symptoms of bipolar depression, they will be diagnosed bipolar depression, no other diagnosis according to DSM-5. So that will be a uniformity thing. So that was a difference between, if we define something on basis of culture, that is abnormal, that is a different thing. This is something which is uniform. Globally, we know that these are the symptoms representing this disorder. So DSM-5 will diagnose like that. Then, in order to clarify what global mental health means to us and how like we can work on it, we need to know the differences of treatment, of diagnosis, and the research should be according to the, like, on different parts of the world, and then we can come up with some concrete thing, which we are lacking right now. That's why we are not able to work on global issues as effectively as it should be, because of something we are lacking. That is some insight into the cultures of different parts of the world. As an example, one of the case study we will be discussing is from Iran. The research article was by Wasig in 2018, and he reported his case study. And he reported a case study of a young girl, and she was like just showing up some moderate to severe depressive symptoms, and she was diagnosed having a clinical depression. There was a long, usually when a person comes into a clinical setting, a long history is taken. So from that history, some points are taken in which that will help a psychotherapist to work on particular thing. Like it's, although there are standardized techniques to work on a bipolar depression, but obviously there are subjective differences in giving treatments depending on the experience of the therapist. Sometimes the therapist finds something in the history on which he said that this could be the working point where I can work on this patient. Let's say in this case what happened, when the girl came to in a clinical setting, she was showing up severe sadness on most days during the past 6 months. She was having irritability. She was having sleep disturbances, which are very common in depressive symptoms, fatigue, excessive thoughts of death, and feelings of worthlessness and guilt. And as per her religious beliefs, now this was the point to be noted by the psychotherapist. As per her religious beliefs, she thought that suicide is a sin, so she denied suicide. She was too much religious person, and the religion she was following was known to the therapist. Rated on that like when a psychotherapist take a history of any individual coming, they also ask to rate on a self-rating scale on a religious scale. So he asked that girl to rate on a religious scale, and she was on above average level on self-related religious scale. That shows that she was very religious in whatever she was following. This was the point noted by therapist, and he based his therapy on the religious beliefs of his client, because luckily the therapist was known to this religion, the religion she was following. And what she was following, like, she was following Shia Islam. Islam has also different sects. So she was following that sect that was, and there are some salient features of Shia Islam which the therapist embedded in his therapy. So these are some features. This sect encourages to remember and repeat the sufferings and virtues of the Prophet Muhammad and his family and children or grandchildren. So this is based on these things. Religious Shias have some ceremonies in which they gather and listen to poems and speeches about the problems and deeds of the Prophet and family. They listen to the problems they have gone through, their families have gone through. And they weep and they pray. And they believe that these ceremonies result in closeness to God and forgiveness of their sins. These mourning ceremonies may have different effects on different people, mentally, psychologically, on their well-being. These ceremonies have different effects on their well-being. So as per these beliefs, the therapist knew it, and he tried to work on these beliefs of the client. And then a unique way of psychotherapy was given to that client. Now, a brief history about her problem. What she was feeling, as I already explained, the depressive symptoms she was feeling were all the clinical diagnoses which were leading her to the clinical depression diagnosis. But the history was that she was very, since she was very religious, she used to go into such ceremonies where she used to listen to the problems of Holy Prophet and and his daughter, and she used to think in a manner that the daughter was very close to the Prophet, and she herself was trying to relate her problem with, like, she was having some problem with her mother, and she was close to her father, and she was relating herself with the daughter of Prophet who loved her father. So that was the basis the therapist found, and he gave a unique way of psychotherapy. Obviously, there is a little, like, it's not a highly researched area. There is a little research available, but when interviewed, these people who go to these kind of ceremonies and who do these ceremonies, they say that even at the intense difficulty in their lives, some trauma or tragic sudden death of some loved one, they were able to come out of depression after going into such ceremony or arranging these ceremonies, in which they cried on the problems of Prophet and their family. And when they cried on their problems and their family, their own problems become lessened, and it minimized their own situations, the problems they are facing. So, and in this school of thought, they have all the examples from all age ranges and male or female in these stories of Prophet and their children. So when they hear to such a story, they might relate it with themselves, and they think that their problem is not more than those problems. So they find a unique way of psychotherapy. That was not possible without knowing the culture. The problem was dealt successfully. And as per World Values Survey, 95% of Iranian people report themselves as religious, so that's why the therapy has to be based on something which will work on them. And 3.6% as not religious, 1.5% as atheist. And 83% religious in America as per this survey, 15.9% not religious, 1.1% are atheists. So proportions somewhat similar to those reported by Americans, and mental health professionals in Iran treat patients according to American textbooks and also follow the DSM criteria. But they also find some indigenous approach to work on a client, and that could be successful. Otherwise, it's sometimes we are following all the criteria of treatment, all the criteria, and the cases are unsuccessful. It's not dealt successfully, but if dealt it intelligently, knowing the culture of the place, if we deal a case, we can save so many problems of mental issues. Then there is some case or a history or something from Japan. I lived in Japan for 6 years, and I worked on the way they used to target mental health, and I found so many differences from other parts of the world. So as an example, just giving you one example, in 1993, National Federation of Families with Mentally Ill Japanese families just requested the Japanese Society of Psychiatry and Neurology to replace the term. There's a term for schizophrenia, Shishin Bunretsu Bio, by a less stigmatizing one like Togo Shitku Sho, that is integration disorder. They said that just change this name into integration disorder because that name has a stigma related to it. And renaming was the need to remove the harmful impact of the diagnosis with the old term on the patients and their families. And then in Japan, many psychiatrists hesitated to inform the patients of the diagnosis of schizophrenia using the old term because of the possible negative consequences on the treatment. So this is an ethics. When somebody is diagnosed with these are the medical ethics and all the ethics used, that when somebody is diagnosed with any disorder, we have to communicate it. So in Japan, in order to communicate it, that will impact the treatment. So they wanted it to be less stigmatized, so they have to communicate, but after communicating, the treatment should not be affected. So after doing this, the use of the new term clearly increased the frequency with which patients were informed of the diagnosis. So otherwise, they were hesitant to inform the patient about the diagnosis. So this helped them in informing the, so it of course impacted the treatment. Then there are some examples from my own case studies, my own clinical experience in Pakistan, which is a developing country, or like the scenario is totally different. So it's another thing which needs attention is that not every psychiatrist or psychologist who is working in a clinical setup is writing their case studies as an article, and it's a very long process to go. Like for me, like living in Pakistan, when I was there and in my clinical setup, I saw cases like on daily basis which could be written and which are unique for the world. They could be in a textbook, but it was not an easy task for me to deal with my client and also write those case studies and send them to the articles or some American Association of Psychiatry or some psychology journals which are considered having higher index or higher level of reliability and credibility. So it is a very difficult process to just publish your article or your case studies, but it doesn't mean that we don't have different kind of case studies. In Pakistan, while I was working there, 1998, personally in my clinical setup, 50% of the women who were coming in that setting were having hysteria or confusion disorder. And that disorder, hysteria, is just rising among uneducated women in villages of Pakistan. And you can just imagine the level of uneducated women. If I'm saying uneducated women, that means they have never been to a primary school, or they have never seen a school in their life. They're living in a village, and they have never seen some educational setting in their lives. So you can imagine what ethics we have to apply now, how to do work here in this part of the world, knowing that they are uneducated. They don't know the difference between psychological health, physical health. They don't know the difference. So awareness and all those things are still like far apart from them. The expert says that developed countries have overcome this abnormality of hysteria or conversion disorder, and the reason is that by discarding descriptive notions associated with women's freedom and sexual orientation, because this particular disorder is related to more women, and it is more related to when they are not allowed to express their feelings, or their sexual orientation is the reason for that. So these are the disorders, 50% in that. And if you open DSM, or if you open any book from Western culture, which we follow in our studies in Pakistan as well, in other underdeveloped countries, we will see that we will follow the same criteria of the West. So that might interrupt with our treatment, diagnosis, and work in these areas. And then there is one case study I just want to discuss here. Miss S, age 17 years, she came to me with a paralysis of right hand without any knowing neurological or other medical conditions since last 3 months. And then she was diagnosed having acute conversion disorder. So what she was doing for these 3 months before coming to me, her family just took her to every kind of healer in Pakistan, except a medical person or a psychologist. Family history indicated that her paralysis was an indication of her unconscious attempt to avoid the responsibilities she was put into and to distract the attention of family from a fight between her eldest brother and her father. That was just, I wanted to make it short, so I'm just giving you one sentence. There was a history of her visits to many non-traditional healers, and also a dissatisfaction was shown from psychotherapists who tried to talk to her, and no medicines were given. So this was the point noted by me. The therapist noted this point, because in Pakistan, when a person comes to a psychiatrist or a psychologist after this much long time, 3 months, it is understood, it is 66% confirmed that they have been through many healers before coming to me. And going to healers and then going to a medical doctor or a clinical setting, when they go to a healer, they think that they might heal them through maybe some kind of herbal medicine or some praying or something done out of the context, like maybe some special kind of prayers will be given and then they might heal. But when they go to a clinic, they expect that they might be given a medicine now. So this was the point noted by me. This is just because knowing that culture. And according to the results of a study conducted in Pakistan, 66% of people who come to psychiatric setting had sought multiple traditional healing methods beforehand. And cultural beliefs and practices often lead to self-care or home remedies in rural areas and consultation with traditional healers. But when they are brought to the clinic for their physical or mental problem, that means they are expecting either an injection or a medicine, or oral pill. So for their recovery, and if not given such a treatment, that is psychologically not effective. So this was a point, only can be done, or if somebody knows the culture, only they can deal it. In this case, particularly in this 17 years old girl case, a placebo, that was a vitamin, was given to the patient without that could be because in the ethics, this cannot be done to a patient without their consent. But this has to be done if we need to just improve the condition, because the hand was shaking and it was in a state of paralysis on her hand. She was not able to do any work, anything. In this case, a placebo was tried with strong suggestions that this placebo has been taken or bought from some other country, and this has to be given to you. And it was successful after finding the beliefs of this client that there should be some medicine related to my problem, otherwise I'm not going to heal. That was something unconscious going inside that patient. That became the successful treatment, and that it only required 2 active sessions, and she was completely fine, and she had follow-up sessions with me, 4 follow-up sessions, and her family still calls me and say thank you just for those 2 sessions which I conducted with her. And that was just because I worked in that culture. I knew what to do. The reason here I know in West it's a no-no thing to give a placebo without involving the family and everyone, and without, of course, it's a ethical question. But what about the quality of life of that patient? Now she's having 2 children. She's enjoying her life. She never had that problem. She thought that that was a situational thing, and that was her teenage, and the history was known to the therapist, and that was how she was dealt. So sometimes we need to know the culture. Sometimes we don't have to be very bookish. Here is the DSM with us, and here are some cultural things with us. We have to pick that thing to work in that particular area, work in that particular culture. There's another case of pseudo pregnancy in Pakistan, and this is a very rare thing, not found here or anywhere else, or not even written in the books. In the book, it is written a case of pseudo pregnancy. What is a pseudo pregnancy? All psychiatrists, psychologists, they learn about this case, but they have never seen it unless they go to this kind of places where I have worked. So pseudo pregnancy in 1999, I had a Mrs. M, age 35. She came to me. All the pregnancy signs were there, enlarged abdomen, but there was an empty uterus. There was no baby inside, but she had all the signs of pregnancy. So instances of pseudo pregnancy are rare, have dropped significantly in US over the last century. In the 1940s, cases of false pregnancy occurred in approximately 1 out of every 250 pregnancies. And that's the reason, if you ask someone here, nobody has seen a case of pseudo pregnancy here. Role of culture. What is the role of culture in this kind of disease? So in countries with easy access to accurate pregnancy tests, pregnancies have become quite rare. Some cultures link a woman's worth with her ability to conceive, and pseudo pregnancy is seen in higher rates in these parts of the world and rare in the Western world. So you can now imagine the pregnancy test kits, how ignorant they are, how much they don't. It's also related to illiterate or uneducated societies. So that's why more cases are there. So what was the treatment decision? Psychotherapy or counseling has to be like keeping that culture in mind, and what decision has to be taken. So this is another example that when we diagnose something, we treat something, we have to take care of the cultural aspect. When we work on any client, we can find a rare case which is not found anywhere, but we can find in some societies due to the cultural factors. So we find those cases. What about the diagnosis now? When I explained abnormality on the basis of maladaptive, I said it's all uniform. We all know that schizophrenia has these symptoms. We all know depression has these symptoms, and if these are the symptoms, then it is a clinical diagnosis. Now, what about some diagnoses, such as gender and identity? What is gender identity disorder, and is it a disorder? It is not a disorder now for some cultures, but it is still a disorder for some cultures. For example, it was like GID, gender identity disorder, was referred as a disorder from 1980 and then revised in 2013. Means in the Western world, it was revised. And in DSM-5, it was eliminated and replaced with body dysphoria. So that was taken out of the category of disorder, and it was just named as body dysphoria, maybe because of stigma related to disorder, or maybe because of political reasons, because they were activists related to this disorder who wanted it to be changed. And that could be any reason. But this change further focused the diagnosis on the gender identity related distress that some transgender people may experience. So that is something related to their depression or their feeling of unfit in the society. So the psychologist or psychiatrist started working on it, and it is now out of that category of disorders. But it is considered as a disorder in many cultures and societies, and especially in Eastern side, and therefore the therapists working all over the world may or may not follow the current criteria of treatment or of diagnosis. Therefore, many therapists, clinicians, or researchers relate the symptoms of body dysphoria in an abnormal category, and they try to treat it, try to treat that person and try to bring up with some therapies which might change their view, what they are thinking. So that is all dependent on the views or practices of that therapist working in that culture. And instead accepting it as a norm, just like in lycomania, there is another disorder, lycomania, which is very rare. Person think that he is a wolf and others cannot see what he can see, such as hair all over the body. Extremely rare disorder. Therefore not received much academic research and is poorly understood, but it is there. With recent research, Bloom 2014 studied multilingual search of historical documents and medical from like he tried to collect cases from 1850 and May 2012. And by the 1800s, physicians had finally more broadly and formally defined it as a delusional belief. So Bloom discovered a couple detailed patient reports from around this time and concluded that physicians are underreporting clinical lycanthropy, both even now and history, in the history. So there were no, because the cases are rare, no activists came up to support that if a person is feeling that they are a wolf, so what's wrong in it? So nobody come up. So that's why it's rare. So there is no known knowledge on it. There is no discussion or debate on it. And then after going through all diagnosis differences, some therapeutic decision differences, and some related cultural differences, and taking a decision of treatment, we can just see what is the overall global statistics, global mental issues statistics. So prevalence of mental disorders remains poorly understood. Therefore, the diagnosis statistics is not close to the true figure due to underreported and underdiagnosed cases. As I told you, it's not easy to always report the case when they come in a clinical setting. High income countries would likely show higher prevalence as a result of more diagnosis. So that's why we don't have that global statistics. We need to work on it. 1 billion people are living with a mental disorder as per these statistics. 3 million deaths from alcohol abuse. And 1 person dies every 40 seconds by suicide globally. And this is a kind of journal statistics, and then some issues related to global mental health. So the current issues are the disparity in provision of care and respect for human rights for developed or underdeveloped countries. And low and middle income countries are home to over 80% of the global population, but command less than 20% of the share of the mental health resources. That is the issue. Failure of humanity in providing basics such as adequate nourishment, clothing, shelter, comfort, and privacy are all well-documented abuses directly related to mental health. And then in low and middle income countries, more than 75% of people with mental, neurological, and substance use disorders receive no treatment for their condition at all. They are not gone to any professional setup. Stigma, discrimination, and human right abuses. These are all issues of global mental health. What are the current works which are going on to improve global mental health? The global mental health field got a big boost in 2013 when WHO launched the first global mental health action plan with the support of health ministers worldwide. And everybody spoke in this forum. And WHO is calling for increased investment. The World Bank endorsed mental health as a global development priority. And while this would have enormous benefits for people, it could deliver a big boost to economies too. So every $1 spent on treatment for anxiety and depression, for example, it will return $5 according to the WHO report. Mental Health Day, which was celebrated first in 1992, and it was the initiative of World Federation for Mental Health, and in which 150 countries were brought together and they discussed different aspects of mental health. And then every year now in October, it is held. This year also, it was held virtually due to the pandemic, and they just take further steps for awareness and educating globally on this issue. So these are the steps going on around the globe. After going all this presentation and all the differences in culture and everything, there are solutions and suggestions to improve, look at this, how to work on the issues. So most important, we need to be culturally literate so that ideas of superiority that indicates that the Western way is the only way to target mental health can be eliminated. So we need to see the broader picture, and that idea that, okay, we follow a standard of DSM-5, we need to bring further changes in it after taking consent of everyone around the world, belonging to different cultures, working in different cultures. We need to revisit of the attempt to implement a Western-oriented mental health system into a different culture, specifically a developing country, related to that first point, that solution. We need to work on religious and global literacy and peace and conflict situations, which will definitely help to create a more sense of well-being globally. So we need to improve we need to bring global literacy and religious literacy in people so that will definitely work every individual and work around the globe. We need to attempt to build a sense of mental wellness rather just treating the disorder. There should be a sense of wellness rather just treat that disorder. That sense could be developed if we know that we are literate in culture, we are literate in religion, we are literate in peace and conflict ideas. Involving local professionals and researchers to suggest their version for diagnostic and statistical manual. So we need to bring everyone in the forum. While I was preparing this presentation, I went through the speeches of people who came and very effectively speak on this topic of global mental health. And I found that those people were sitting on the level of like on a administrative level who were deciding things, but there was a lack of professional people who really were working in the villages of developing countries, of underdeveloped countries, who are really belonging to these people, who are working in it, who have the case studies to discuss there. That was lacking in those forums of worldwide conferences. So bringing them together is a wonderful idea, but bringing some local professionals is making them at the optimum level of work. Mental health problems are related to poverty, violence, lack of education. Therefore, it is a need to target different problems. It's not that we have to target the mental health. It's that we have to target the basic needs. That will make a society, that will make an individual to grow to the best level. And that is what is required in this global world. According to Volkan, his research explained that the acceptance of psychotherapy does not vary solely between countries, but also between various ethnic cultural groups within the same country, as explained. So it's not that we are just working on one country or one as we are also working on different small segments. And I can give you one example from my own, the country I belong, Pakistan. In Pakistan, after every 3 kilometers, the culture change, the language change, the food change, and we are living in a society, in a country in which there are so many different segments and different, like you have different, here in America there are different states, we have different states, and every state might be having a different dialect or maybe some tradition related to, let's say, in Texas there are some traditions related to it. So in Pakistan, I know it's such a small country, I think the whole Texas is bigger than Pakistan. Pakistan is such a small country, but it's every 3 kilometers, food is changed, dress is changed, language is changed. We have so many different regional languages. So belonging on that, we have different cultures. And while working there, I was among those therapists who only was good in one part of Pakistan. Like I was knowing that culture only, where I was working, to that villages, but not on the other side. So I need to improve my knowledge in that while going there and working there, even that country, I lived there. So that is why which we need to bring people from there, educate ourselves, and then work on it. To make a global database in which psychotherapists all around the world can record their clinical practices. This is something very close to my heart. And the reason of a successful or unsuccessful therapy should be documented there. Because it's really, really hard, because I, as an academician, as a researcher, I can tell you how difficult it was for me when I was, now it is okay. I am here, I'm meeting many brilliant researchers here, and I can write my research or an article with their help, and we can work as a team. When I was in Pakistan, I was working with so many brilliant people, but when we have to send an article to some credible journal, it was very difficult. We needed some simple system to report our cases so that everyone all around the world can see those cases and see what therapy we have given them, and they can see why the therapy was successful and why it was unsuccessful. So that's a requirement, a database, global database for global mental health. We need to put global efforts to remove stigma. So this is the part, I think we need a whole full-fledged 1 hour talk on how to remove stigma. We need to work on it. We need to create that awareness that stigma related to certain diseases, and mental health is one of them. We are not talking about it. We are also not, even how can we talk, if I'm going through some mental problem, how can I talk about it when my society is telling me, since I was born, I know that in underdeveloped countries or developing countries, or such as in Pakistan, when a person is raised in that society, there is one institution, very strong institution of like army. Nobody can enter the army if they are having some problems, and nobody can just, because they are gone through IQ test, all the tests they are done, and then they are selected for army services. And also when they have to go through that psychological testing. So if somebody is found having some kind of problem, they will be rejected, they won't be accepted. And this is one institute, and this happens for many institutes. If you want to be a doctor, you have to be mentally no problem, as like you're not in your control. So this is when a person is raised up in this kind of society, they know that if I am suffering from something, I don't have to tell anyone. I don't have to tell anyone, otherwise my career will be affected, or otherwise people will be affected around me. So that is something really hurting me always. Whenever I saw a client kind of who come to me and they said, I am suffering from last 28 years. And I worked for some army personnel over there who were like suffering from PTSD, which is so common everywhere, who has gone through a war scene, or who has gone through so many army exercises. They suffer from PTSD, and it is so common, it happens. They have not seen that, like that, some trauma related to them. They have seen something which is very unexpected, and there is some trauma related to their attitude, and their behavior is changed. So they cannot tell anyone, because they want to show that they are strong army personnel, and showing them will be showing a weakness, and that will be just damaging their image as a strong man. That is a stigma. Then we need to try to treat the person, instead the disorder. Therefore, we need a customized treatment to deal globally. That's what my point is, that why we should know the culture, why we should know the background of anyone who is coming and telling us any problem or any mental health issue. So because we are trying to deal the disorder, we are not looking at the person as a whole with the culture and everything. So if someone comes to treat their depression here, let's say, in Western society, they come here in a clinic, and that person belongs to a culture somewhere in Uganda. The therapist should know the culture of that place, so that in order to deal that disorder, it's not sometimes only the medicine working, it's the psychotherapy also working, and that psychotherapy will be effective only when the person knows the culture of the person who's sitting in front of them. So these are some suggestions, and last but not least, we need to understand that when it comes to any health, there is no them, but only us. So we need to do like that. These are some references. Thank you very much.